Thank you for joining us and welcome to our presentation today on telemedicine best practices in response to COVID-19. We are excited to bring to you this live interview session today between Ron Emerson of AMD Global Telemedicine and Dr. Yudi Prasad from Bronx Care Healthcare System. Ron will be interviewing Dr. Prasad to help get some insights from someone who is on the front lines of addressing COVID-19 to find out how they have and will be using telehealth to address patients' needs. And then following this discussion, Ron will be highlighting the positive changes to reimbursement and policies for telehealth, as well as providing some examples of telemedicine delivery models for COVID-19 screening and cases. But before we get started, just know that we will open up the discussion to your questions following the interview with Dr. Prasad. So if you do have questions along the way, feel free to type them into the question box at the bottom of your Zoom screen. You'll see a button for Q&A. Just go ahead and type in the questions there, and then we'll try to go through as many of them as we can after the interview. And now I'll turn it over to Ron Emerson.
All right, thank you very much, Carrie. And I'd just like to give a special thanks to Dr. Prasad for joining us today to talk about such an important topic. And I also want to thank all of you for taking time out of your busy schedules with everything that's going on. Just to let you know, as Carrie said, we'll be interviewing Dr. Prasad. We're going to keep this webinar to as close as we can to a half an hour, given the time constraints a lot of folks have right now. So Dr. Prasad, it's a pleasure to have you on here, sir. And just a few questions I want to start out with. So, what we're going to do during this interview is we want to relate sort of the signs and symptoms and the reality of what you're seeing with COVID-19, and not just COVID-19, but just everyday medical needs and concerns that people have and ways to use telemedicine. So let's focus a little bit on the COVID-19 right now. Can you just describe, because a lot of folks on the call, unfortunately, haven't seen any cases yet, of what you and your colleagues are seeing in regards to the clinical presentation of patients who are presenting positive with COVID-19?
Yeah, thanks. Yep, go ahead. Thanks, Ron. What we're seeing here is not any different than every major city. We are located in New York, and probably New York has been, as everyone's seen on the news, hit the hardest. Our hospital is located in the Bronx, and right now we have the highest rate per 100,000 population. We're also the poorest congressional district in the entire United States. So with that comes a disparity of healthcare. So we see a lot of patients with comorbid conditions such as hypertension, diabetes, lung disease, and obesity. And unfortunately, these are the conditions that tend to affect patients the most and have the worst prognosis. So currently we're seeing patients as young as a few months old to we're seeing the elderly. The good news is that the young tend to do better, but the elderly do not. This disease is so interesting because you can come in with very mild symptoms, or you can be very severe symptoms. And just like that, it can affect you. So some of the mild symptoms we're seeing is most patients come in with just basic fever, coughing, fatigue, body aches, sore throat. Sometimes their taste or their smell is affected as well. For the severe patient, there's respiratory distress or low oxygenation, and that can also affect them. So we're seeing all types of patients.
Okay, now, okay, thank you very much. No, that's a great in-depth answer. So, one of the things that we're getting a lot of questions on in regards to telehealth is, of course, there's guidelines by the CDC, and one of the questions is that we want to ask you is, the management of patients who have tested positive for COVID-19. So we have that group, we know that they're positive. And if they're not exhibiting those severe symptoms, like you said, where they do not need to be hospitalized, that's one group. But then there's another group that is showing signs and symptoms that they haven't come in, they haven't increased exposure to others, and basically treating them in place in their own location. So can you briefly just go over what you're seeing from a treatment perspective in the CDC guidelines on how to manage those two groups of patients if they're not severe enough to be in the hospital?
Sure, I think right, Mr. Emerson, decreasing exposure of our patients is absolutely a priority. We have been following the CDC guidelines very carefully. We also know that since the beginning of March, ending of February, the guidelines have also changed. So this is something that we have to keep up to date on to see what's going on. So most of these patients that you spoke about are mild, or they are exhibiting some symptoms such as fever and coughing. And the CDC definitely recommends that you have to stay home or you quarantine yourself and not expose others. They also recommend that you keep in touch with your provider. And we know that that has been an extreme problem. A lot of practices are closed, facilities are closing down. So the access to care is very limited to a lot of the patients, and this causes a problem. We have been very fortunate at Bronx Care to be able to keep all our services open, so we can provide that access to care to the patients. However, from the mild, there's also some emergency signs, right? So the CDC basically says that if a patient has four signs, either trouble breathing, or they have a persistent pain and a pressure in the chest, or they have a new confusion or an inability to arouse them, or their lips or their face turns blue, then they need urgent treatment and they need to go to either an urgent care, or ER, or a hospital on an emergent basis. So you are right, there's different buckets of patients that we have to deal with.
Okay, no, that's great. So, and the interesting part is as we look at using distant technology to help manage that, because as you say, there's going to be patients that they can be managed in their home safely, they self-quarantine, but continuing to keep an eye and contact with their physicians, as you mentioned earlier, which could be the phone or video calls. So now we're going to kind of switch gears a little bit and sort of relate this to, as we've looked at the clinical symptoms and the CDC guidelines, is just some of the things that you're doing now and that you're planning on doing. Of course, as I said, you're the clinical lead for your telehealth group, and you're right in the middle of this and moving faster than others. But given that patients will be quarantined, and regardless if they're positive, they're not, or if they have not been tested positive, but they need to be quarantined based on symptoms, or maybe they went out of state or whatever it might be, how do you envision the full optimization of technology to treat these patients?
I think the bottom line is that technology is here to stay, and we have to incorporate it properly. Telemedicine as a whole is being used in every aspect of different fields of medicine. So for the last 2 weeks, as soon, more than 2 weeks, when the pandemic hit, we were getting ready to use telehealth. And we've done intense training with each of the department chairmen, a lot of the providers, so that they become more comfortable with using it and giving them their options and what can be done. I think to be able to fully optimize or full optimization of telemedicine is when we can connect the entire community. And I think that's going to be a goal in the future. And this pandemic has given us a lot of teaching experiences and things that we can learn from.
Yeah, and we've seen a lot of, which I'll be talking about in the next part of the presentation, is the regulatory and policy, where as you look at sustainability and cost effectiveness, that's been pushed through for this, even for like Medicare and different things and state Medicaids. You know, it's unfortunate that it's taken a pandemic to escalate these things to this level, but telehealth has a really unique opportunity to be embedded, as you said, into sort of the fabric of the way that we do, as the way that we provide health and move this. So, and it's an interesting point, because, you know, and I'll talk about this in my presentation as well. Some of the models that we see, like with what, you know, you folks are doing some and what others is, it's about just decreasing exposure. And they're using telehealth as a way to treat people that do have COVID or are suspected of COVID because of symptoms. But, you know, also is other symptoms and other elements that we have on a day-to-day basis just don't go away, right? We still have those day-to-day things that people were using technologies in their home anyhow. So it's a great way to decrease exposure for those folks. So as we kind of move out of the home at AMD, we have a, saying, of course, in medicine, and I'm a nurse, you know, I remember in school, there was all about the continuum of care, right? From the home to the physician's office, maybe a critical care access hospital, up to a hospital, to a tertiary center. We basically call it the virtual continuum of care, which is how do we provide all those touch points as we're using distant technology to have those interactions. So let's move away from the home and just talk about the continuum of care and how that affects, how do you see telemedicine being used within facilities like hospitals, clinics, maybe, and even like skilled nursing facilities where we do have an aged population. So how do you see more diagnostic telemedicine with devices and things being used rather than just in the home with like a mobile device or something?
Yeah, I think you hit on a bunch of stuff there, but the technology has advanced. Remember, so all the new equipment and the new technology is only there to make it easier for us to do proper examination and make proper diagnoses on our patients. So Currently, we're using it in all aspects in the hospitals and also our clinics and even our nursing homes. You know, those are the most vulnerable population, and these are the patients that we need to connect with our specialists so that they don't go to the emergency room or have to leave the nursing home. So I think we're at the right time right now where all this is going to be helping us to make the proper diagnosis. The bottom line about telemedicine is that, you know, we've been providing care to our patients, and there's a certain way that we're used to doing that. And telemedicine is only going to help us to continue that care. Is there differences here and there? Yes, but there's also a learning curve involved with it in each institution. And I think we're ready for the challenge as well.
No, that's great. That's a great overview. Okay, I don't want to take up too much of your time, Doctor. We know how busy you are down there. So, do you just have anything else that you'd like to share to the team or group based on it can be from a clinical perspective or just about COVID-19 or just your sort of your telehealth journey in general as you go through this and it's being escalated because of the unfortunate current situation?
Yeah, no, number one, I would just like to thank, you know, everyone that's doing their part to help with this horrible thing that's happening to everyone, and everyone is affected, family, friends, colleagues, and everyone is doing their best. As far as telemedicine is concerned, you know, it's nothing new. Telemedicine has been around since the 1800s. And then the NASA astronauts were using it. So it's not a new thing. So to echo what some of the experts in the field are saying, there's a paradigm shift in healthcare, and telemedicine or telehealthcare is here to stay, and we should learn from that.
Okay. Okay, wonderful. Okay, now we're going to go to questions. So, Carrie, I'm going to hand it over to you, and I can actually manage some of the questions as well, Carrie. But
Okay.
but go right ahead.
One question that came up is how do you envision, you know, what you are using today for technology? Is that something that you can use, you know, moving forward? You talked about the everything's here to stay, and so how do you envision that, you know, things you use today can be used in the future too, so you don't just spend money on the current situation, but your investment is more long term?
Right. So the good thing with us was that we were heavily researching and investigating all aspects of telehealth for the last 2 years. So there was a lot of things that worked and many things that did not work. You know, our hospital is not the richest hospital in the sense that, and most hospital systems are not. So we saw where the failures were, and we try to minimize that for the future. But I think there's enough case studies, and we're seeing where it is being successfully used, and we're learning from that. It's all a learning experience and learning from each other, and I think that's how we move forward from that.
I have another another question here. And then we have a few more popping up here. The question is when you look at your clinicians in your leadership in your organization, how did you get buy-in before the pandemic to integrate telehealth into the way that you planned on providing care to the patients of the Bronx? And how has that changed with the current epidemic or the current pandemic now?
Yeah, so, you know, it's a learning curve when it comes on the education of what telehealth is. There's a lot of misconceptions on it as well. And you have to reach out to everyone in your organization to get the buy-in. There's a lot of providers that were against it. But, you know, it reminds me of when we implemented EMR, you know, electronic medical record. And it was the same things. We went through all the stages of frustration, anger, depression. So it's the same thing we saw with telehealth. So the bottom line is we want to say that telehealth is not here to change the way you practice. It wants to help you on the way to practice. So I think that's how we got buy-in from a clinical standpoint. Now, when it came down to the return on investment, obviously the return on investment was not there unless you're looking at a cost savings model. So now with the legislation changing day by day, we see that all that, it's now full parity. You know, it depends on what state you're in, obviously. New York, they've been very lenient. Medicaid and now Medicare has been very lenient. So the return on investment is a no-brainer since parity is here. So, you know, those things, it's a struggle, and it continues to be a struggle to get everyone to get bought in. And, you know, at the end of the road, I want the patients to buy in. So that's the bottom line. And I'm, you know, as I said before, we're in a very poor congressional district, and we were surprised to know that about 70% of our patients did have access to a smartphone, which was great.
Wow.
And then they have someone in their homes that have access to a smartphone. So once we use that technology and patients starts to get, accustomed to it, a lot of them like it a lot. So I think it's still a learning curve, and it's an everyday work to get everyone to buy in. And you continue to do that.
No, I appreciate that, because one of the things that I've been doing telemedicine for 20 years, and I think you just hit all the points. I say, what are the different things that when you're working with an organization, that the stages or things that are going to have to be addressed along the way. And some of you that have heard me speak before, I always say, the first thing is, we're here to serve the patients, and it's patient satisfaction. Do patients like it, as you said, doctor, to get patient buy-in and feel comfortable with the experience and the care they're receiving. The second thing is, from a clinician perspective, is clinical efficacy, right? Do clinicians feel comfortable that they can provide the level of care based on the intent of the technology? So you and I know, if you're using this in the home, the intent is different than, of course, without diagnostic capabilities, where you can't catch some objective data that you can't get that you normally would if the patient was in the office, right? But you just have to know what the intent is and when to escalate. And then the third one, of course, you also mentioned, doctor, is just the financial part of it is the business model of how do you increase revenue or decrease cost by the use of telemedicine. And if you kind of cover those 3 points, I just thought, after doing this for 20-something years, like, what are the things we're always challenged on that we have to prove with systems? And if you think about it, those are some of the key things. So, okay, Carrie, do you have see, we have another question?
Yeah. How do you see this technology being incorporated into the workplace employer on-site health clinics?
Interesting. Go ahead, doctor. I have a thought on that one, but if you want to talk about it, go right ahead.
So the question is, how do we incorporate it in our clinics?
No, how do you, in your opinion, on how you see this maybe not necessarily, well, Bronx Care maybe, or other places, how can this be incorporated into bringing the care on site at employee sites?
Oh, at employee site, very easy. I mean, we've started it already. This care can be given in every aspect of the organization or every aspect of the community. I think you have to learn the technology, you have to learn about the benefits, how it can be used. And the one thing is that it's not the same template for every division and every department. There's some clinics where it's going to work and some that it's not going to work. So I always say that it's good to have champions or people that's going to, one, work with the team to see what their needs are and to incorporate it that way. So that's the stance that we like to take on it.
Yeah, and that's a great answer, and that's kind of the clinical side. But a little to add on to what the doctor said is, that's one of our fastest growth areas. We have a lot of self-insured employers out there who are really struggling. They have sort of catastrophic plans, but the employees aren't seeing as many benefits. So actually, what telemedicine has provided is it's really provided a different scale. Because if you look historically, to actually have physicians or even mid-levels actually in a clinic, you have to have a certain number of employees, right? And that number can differ based on who you ask. Let's say it's 2,500, 3,000. But with telemedicine, having a nurse there with the technology, you could have a good doctor like Dr. Prasad who could cover 5 or 6 or 7 different sites to get that volume and that capacity, where telemedicine makes sense, and they have something a little more tangible for their employees, where they can go to the clinic anytime they want, and there's a nurse there, and then they connect to the clinician on the other side. So. Yeah. All right. Well, doctor, we know how busy you are, and I said I wasn't going to take a lot of your time, and we have quite a few more questions here, but I'm gonna let you go on that, so I'll do my part. But just a huge thank you, and it's and good stuff. We really appreciate your time. How busy you are there. Okay. Thank you very much. All right. I will continue then. So just a special.
Sorry, we have some questions that are coming in, so if people continue to type in questions, feel free. And Dr. Prasad, if you're still on, maybe we can address them at the end, or Ron, you can address some of them. So just continue.
No, I would like that. If Dr. Prasad, if you can stay to the end, I'll bring you back in and we can both answer questions at the same time together. Is that okay?
Yeah, sure.
Okay, wonderful. Thank you. All right. So, okay. So we did that. So what I'm going to talk about, I'm just going to go over some of the different models as we talk to different organizations, all across the country. And what we're looking at from best practices. But one of the first things that a lot of organizations, as the doctor talked about, was, as Dr. Prasad talked about, was looking at actual reimbursement and sustainability. So let's just talk about some of the real positive changes that have happened recently because of this push with the pandemic. The first thing is when you look at CMS, of course, we have three payers. We have Medicare, we have Medicaid, and we have privates, right? In general, that's the mix in the US, which is where the audience on here is from. Is there's a lot of new Medicare telehealth regs. And what Carrie will do is after this presentation, she will actually post this and send out to you a recording of Dr. Prasad and myself doing the webinar, but she'll also provide the slides to you so that you can look at the information I have here and you'll have it. But if you look at actual reimbursement, there's a lot of different changes. I'm going to talk about some of the big ones that I think are the big ones. One of the big ones for Medicare is if you look down right here, there's no originating site restrictions, okay? Before, if you remember with telemedicine for Medicare reimbursement, the patient had to be physically located in a non-metropolitan statistical area or in a HIPSA. So they couldn't be in a city with above 50,000 people. So for people like for organizations like Bronx Care and Dr. Prasad, that would be a killer for reimbursement, right? Because they are in a metro area. And we all know there's not always a correlation between where you're at and if you have access, because cities can sometimes be huge barriers, especially when you look from an international and with traffic and different. So that's been removed. Under the CARES Act, something else that was removed recently was the requirement for a 3-year existing provider-patient relationship. So what they said is that the reimbursement could happen and you could do a video call to a patient at home for Medicare, but you had to have an ongoing relationship, so they didn't want other clinicians, and they've waived that as well. So they really see the need of people to be able to not just get the treatment for the COVID-19 signs and symptoms, but there's just those everyday ailments. You can see all the new changes at the tops: critical care services, additional CPT codes, home visits, initial continuing intensive care services. It just goes on and on. Parity telehealth services, Medicare, they can now report the point of service code that would have been reported had the service been furnished in person. So before you had to use a different one for telehealth, so they're treating it as in person. Virtual check-ins, I'm not going to go over all this because there's just too much, but as I said, you'll get the slides. And then if you look at FHQCs and rural health clinics, there's been expansion there. So we've had a significant expansion of telehealth reimbursement on the Medicare side and also at the state level. There's been some confusion, just to be clear. There's been some confusion with folks out there, and a question we get is, what about the licensure that has taken place, right? We know with the Medical Interstate Compact Act, clinicians, you know, and more states than not had the option that they could use the Interstate Medical Compact Act to escalate and decrease the time it takes to get licensed in a different state. I think there was a little bit of confusion because President Trump, they put something on about licensure, interstate licensure, but of course, licensure is still a state function. It's still a state, the state medical boards decide who and can and cannot be, but there are certain states, and you would have to check with your, own organization to your own state Medicaid to see Medicaid and the state medical boards, to ensure that they've lifted medical licensure restrictions if you want to use physicians from a different state. Okay, that's important. But just don't think you can do it. Check with your state first on the other side. So let's talk about some of the delivery models and best practices that we're seeing on top of what Dr. Prasad said, because he gave us some really good insight from a perspective. Some of you on this call are very new to telemedicine. Others of us have been on this journey for a while, so bear with me, those of you that have. Types of telemedicine at a high level, you know, telemedicine means telehealth means a transfer of electronic medical data, right? That's sort of the high level umbrella term. And when I was on the board of the American Telemedicine Association many years ago, you know, it was a big topic. And sort of over the years, it's filtered down that that's the high level term. And then telemedicine now, in most parties and most groups that you talk to, means like an interaction between a clinician and a patient to provide clinical care. So what we call diagnostic telemedicine is where you would have, like the Bronx Care example, at one of the facilities, you could have Dr. Prasad. He could be in his office as an immunologist, an allergist, and he could be seeing a patient, let's say in the skilled nursing facility on one of these, and you can connect. We have over 40 different medical devices. So from a clinical perspective, you know, the goal of diagnostic telemedicine is to provide as close to the level of same care from a distance you would in person. And these are facility-based, so you need a nurse with the patient, or you need someone to actually help control the technology and to assess the patient. and it's supported by a patient. And like I say, it's all about medical diagnostics. So when you look at diagnostic telemedicine from a clinical expertise area, what are we seeing in actual experiences? And then what are we seeing people actually wanting to use the technology for? One is just to provide support from an area with COVID-19 experience to an area that does not have experience. So this could be a regional or state level. You could get doctors like Dr. Prasad or some of the infectious disease docs, or maybe there's secondary complications, which we know there are from this, where there are pneumonias and how to best treat, where you can have that expertise from areas that are dealing with this and have experience, which we know is very critical, to areas that don't. Within a system, or the expertise, not just in the system, but then actually cross state or wherever we need to go with it. But as we know, and we've all seen, and the doctor gave some good overviews on this as well, Dr. Prasad, is that, provide specialty support and treatment in complex patients. So the initial diagnosis and initial initiation could be the COVID-19, but then we have all the secondary issues, and we have, of course, there's more risk, as the doctor said, with patients with diabetes and the age. So we have all these secondary. So we need to bring more specialists in to be able to do that. One use case that we really weren't expecting as much, but we're seeing more of and a lot more interest, is just utilizing telehealth, using that cart that I showed you, bringing it into a patient's room, because a lot of these patients can have, you have I'll say a primary care doc, and then you have an infectious disease doc, as managing the patient on day to day, but then you have a lot of other specialists. They bring specialists like Dr. Prasad in, and, to decrease exposure, they just want the telemedicine equipment in the room with the patient, where even from the nurse's desk, multiple physicians can go in. If there's a nurse in there, they can listen to heart and lung sounds. With the stethoscopes, they have scopes where they could look at the throat or look at other things that are going on with the patient. Of course, temperature and everything is already done from the other side. And you can even hook spirometry up to these and bring it out to the other side. So that's a use case we really weren't expecting as much, but we're seeing a lot more interest, and we're seeing folks starting to initiate and utilize the technology within the facility themselves. Some of the most popular settings, of course, skilled nursing facilities, as Dr. Prasad said, because that's one of the things they're doing. High risk area. We don't want, of course, once it gets inside of a facility, we have some real issues as far as the exposure. Hospitals, and then, of course, outpatient settings in clinics. Okay, so that's one of the key areas. So focus on diagnostic and some of the use cases. Now, the other thing that Dr. Prasad talked about was in-home treatment, and he gave an overview of the CD guidelines. And I always say, again, as the doctor did, and he's a clinician, a physician, he can speak to this, where I can't as much. But if you look at the CD guidelines as of now, which I just checked before this, it basically is not all patients with COVID-19 require hospitalization, as we know, and patients whose clinical presentation warrants a patient clinical management support measures, they can be in their home, and that's where they would work with their clinician, their physician, and be monitored and under quarantine and have guidance, right? But with that is, what do they actually use for technology, and how are we using this? So it's basically, we just call it, it's for those of you that are new to telehealth, it's called direct to consumer. And all that means is the patients on their phones would have an app or something that they download. And on the back end, where the provider is, they have a full back end workflow where they can actually integrate these back end systems into their technology. Now, this is getting more sophisticated. It's for higher volume. You can schedule appointments. You can have queuing systems where they queue up, the patients do, and you have maybe 5 or 6 doctors, and the doctor can answer from their phone, or they can answer from their computer, whatever they want. But this is what's called direct to consumer, and this is that home piece that we were talking about earlier when I interviewed Dr. Prasad. So the clinical use cases. How do we treat patients in place with COVID-19 signs and symptoms, and we follow the CDC guidelines? And that doesn't mean that they're positive, right? That means that they just have a condition going on, but you don't want to bring them in for increased exposure to themselves. If they don't have it, or if they do have it, we don't want to expose others. And of course, again, they change frequently, but base that on what the CDC treatment guidelines tell you what to do when you're clinicians. Treat patients who are positive. That's an easy one, as the doctor said earlier. Keep an eye on it and monitor, and they need to have contact with their clinicians. And this is a great way to do it over the technology, where you can actually see the patient, respirations, and if they look like they're in distress, and just how they look clinically. And then one thing we kind of forget about, I think we're so focused on COVID-19 that there's just everyday things that happen. Dr. Prasad is an allergist. He still has people that are highly allergic to things or having anaphylactic reactions, and he needs to treat those patients and try to provide care to them. So using distant technology such as this to provide treatment and continue sort of that continuity of care without exposing an increase in patients when they come in is very, very important. And this is all about, and I had met with a doctor before this and other clinicians that we've talked to, and we all realize is how can we use distant technologies to treat the things we need to today, to continue what we have always had going on before COVID-19, but to also decrease exposure to the patients, to healthcare professionals, because if we lose our clinicians and our nurses, healthcare systems literally go to their knees, right? It's bad enough that people in the community are getting it, but we have to protect and decrease exposure as much as we can to our professionals and, of course, other patients. So with that, I'm going to stop, and I'm going to hand it back over to Carrie for questions for Dr. Prasad. Carrie, you're probably muted.
Thank you. Just to repeat it, a few of you had asked the question about the slides, so there will be recording, the link to the recording as well as the slides sent to each of you who participated in this webinar. And for the questions, let me just pull up. We had a couple about okay. So what are the biggest technology barriers that you see in taking a fixed base diagnostic medical service and making it a telehealth medical service, if you have an example, if possible?
Yeah, I can speak to that, or doctor, you can speak to that first if you like. Do you want to take that one, or do you want me to jump in?
First. Yeah, you could go.
Yeah, no, it's interesting. So this is what we have all the time, right? So this is something we deal with, and I used to run a large telehealth network up in the Northeast, and you know, I talked about sort of the three key things that we talked about, that it has to make sense. We have to be able to have a good experience for patients. We have to be able to provide clinical efficacy, and we have to make business sense out of it, of why we're doing it, right? I think those are the key three things. So the first thing that I think is the most important out of all my years of telemedicine, and I've been to 47 countries working on different telemedicine programs in my career, and if it's a public sector, private sector, everything is what we see very common, and this is a very general answer, but it's so true, and Dr. Prasad's working through this now, is if you do not have the leadership integrate telehealth into the strategy of how you plan to take care of a given population or a clinical service, then what you'll end up having is you'll have good caring doctors, a few of them that really want to do a good thing, and you'll hear about this program and it's going great. And then one doctor or two doctors move away and you find out the whole program collapsed. And there's probably a lot of people on here shaking their heads saying, yeah, I'm in that situation right now. So the biggest thing is, from a strategic perspective, you need to get the organization to align telehealth with its goals of how it's going to take care of its patients. So that's number one as far as switching from a facility-based system, telemedicine. The next part of it is making it very easy for the clinicians and just integrating it into traditional workflow. Clinicians are busy. If they're employed by the hospital, it's expensive. The hospital's basically paying for their hourly rate, right? So we have to be able to increase or at least match the workflow and integrate so that they can provide care as efficiently from a distance as they would if it was in person. And then the third thing that you have to do, which is very important, is when you look at the model that I just said, is look at from a business perspective how that's going to work in a private healthcare system like we work in the US. And two things, I'll give a couple answers. You know, we're going under quality-based care and we're seeing more capitated rates. So let's just use example of a skilled nursing facility. It's $425 a day if the patient's in the SNF. If they're outside of the skilled nursing facility and have to go to a hospital, then that skilled nursing facility is losing the $425 a day. They're under accountable care now, right? Quality-based care. For unnecessary admissions, there's penalties. So they look at all of these different things, and this is on top of just the obvious thing, which is what we all got in healthcare for, is that we just want to provide better access to care, and there's a correlation between access to care and quality of care. We all know that, right? So in short, if you look at those things that I just talked about, from moving that model, and I'm happy to have those conversations with you. I've done a lot of business plans with organizations as they move. We have the technology down. We can do it with the technology. The technology is not the issue. Reimbursement in the business plan, because every organization is different, is the thing that you really got to dig into and to come out the other side. Really long answer, I'm sorry, but go ahead, doctor.
Yeah, I think you hit it all, the great point. You know, when we started about 2 years ago, we created a roadmap. And at the beginning of that, you always have to ask one question. What is your goals of your clinic, your organization? Once you get the goal, then you can go and get the buy-in from the providers and the patients. You know, we are in a distinct or unique environment here in the Bronx. So we have to understand our patients, what they like, what they don't like. And then you see how you can accomplish that. You know, as I said before, not one telehealth program works for everyone. And every clinic is unique. So once you do the background research on that, I think it's easy to start putting the technology in place and getting everyone to go with it. So I think the first question is, what are your goals?
Great point. And I just want to be cognizant of time. We do still have questions coming in, so we can continue and keep going if you want. And for those of you that have to log off, because we've gone a little past that half hour we promised, just want to say thank you for those of you that do have to go. We thank you for participating in the webinar, and we'll send you some follow-up information with the link in the recording. Ron and Dr. Prasad, if you're okay, I will continue on with a few more questions.
Sure.
I'm good. Yeah.
So question comes in, do you see this as a means to retain primary care physicians that would then allow them to work from home?
Yeah, I think you know, as a physician, there is such a thing as physician burnout. And I think when you use telehealth to retain a lot of your physician and make them have the satisfaction as well. We've seen during this pandemic that the physicians are going through such a hard time, and for a long time, a lot of people have not really listened to them. I think once they start using the telehealth, you're going to have a great buy-in from them, and they're going to be more loyal to your organization. I think it's very important to look at it that way. And in areas where it's hard to recruit, you know, different people have different needs. Using telehealth for a provider just makes a lot of sense. So I definitely think you can use it that way.
Yeah, and just to add on to that, you know, I think one of the great examples of that, doctor, is I'm from a very small town in northern Michigan, in the Upper Peninsula of Michigan, and we have primary care doctors that they do a lot of different things because they have very few specialists. And one of the and as the question was about primary care providers is one of the things that they've had to manage is they do a lot of the inpatient care. And what we are seeing in telehealth is there are organizations out there that are actually customers of ours that are providing hospitalists to these rural hospitals. So after hours, the hospitalists, by the use of telemedicine, are providing clinical care to those organizations that have trouble recruiting hospitalists because they just don't have the volume. They don't have enough beds to justify having a full-time hospitalist, and burnout. And this is helping significantly with the issue that you just mentioned.
Okay. There's a lot of good questions, so I have to pick and choose here. One question is, can you touch on, I'm not sure if you're doing this, Dr. Prasad, but can you touch on testing services for coronavirus, meaning being able to provide a testing in real time, not have to wait for days for result after the test has been taken? Or how are you addressing the testing?
Yeah, I think nationally, we've always had an issue with testing, right? And we just had a training for one of the departments who had that specific question. So a patient has to have surgery. They need to do the COVID testing on that patient. So we have our lab here that has been very connected. So now you can see the patient via the video consult, and you can refer them to get the testing for those patients that need it. I think what I'm seeing more is a lot of patients want to go get tested, and a lot of the times they don't need to be tested. I think this disease is so predominant and it's so high that we're pretty sure that they already had it. And we already know that this disease has been around for months. We're not sure how long, but before this pandemic became a pandemic, a lot of our patients had it. So again, I think you have to work with the system you're in. I know other places outside of New York, we have drive-throughs where we can go get the testing done there as well. So you have to see what you have as far as infrastructure, where the testing is being done currently, and how you can communicate with those patients. And then you have to decide which of those patients need the testing and which don't. So I think it depends on your area.
Okay, great. Here's a question. This might be to both of you, actually. How can we use telemedicine devices in COVID-19 clinics when we want to minimize exposure to our clinicians? So maybe an example of how that would go.
Right. So two things. The equipment you will need when you're evaluating COVID is a bunch. So if you have a site, and Ron spoke about the diagnostic telemedicine, where you have the carts or the equipment set up, you can actually have a virtual stethoscope where you can listen to the lungs. You could have a thermometer where you could take the temperature on that patient. And there's a lot of little tools that the physician does not need to be there at the same time. A lot of my patients as well, I've had them order, they're in their homes, they feel like they're having difficulty breathing. A lot of them are asthmatics. They can't tell the difference between asthma, COVID, or anxiety. So I ask them to order a pulse ox if they don't have one. So these are things that we can use to help us make our diagnosis from far away. And it's only going to get better. You know, all these different equipment is now more predominant.
No, that's good points. And I actually thought about that. I mapped that out like from a distance when you look at the symptoms. And of course the doctor can add more than this, but I thought one is just to look at, the overall clinical presentation of a patient and like what their cough looks like. That would be basic video conferencing like we're doing right now. Right. And, are they shortness of breath as far as them walking? So you get a clinical presentation of how they look. Another one I thought about was, and the doctor touched on this, is when you look at, of course, just basic like vital signs monitors for like a pulse oximetry and temperature would be the two there. Then the other one was heart and lung sounds. Of course, that makes sense. And I think we are starting to see some cardiac symptoms associated with this as well. At least that's what I saw, not clinically, but you can, I saw it on a CDC report. And then, spirometry, just overall pulmonary function. And I don't know how useful that would be if you would actually need to do that, doctor, very much, but just to see how affected someone is from this. And then those are the big ones. You could use scopes to look in the throat, but I think anything could cause a sore throat. That's probably one of the symptoms that you look at, but we can do all of these. So, and then of course, so from a distance, when we kind of match all the signs and symptoms from a diagnostic telemedicine perspective, there's really nothing that we can't provide from a testing perspective, even EKGs that you would do if they were actually in a different location or if they were just in a room. So that's kind of matching the symptoms to the actual technology. The doctor did a good job, but I actually jotted something out and thought about that one time. So I think we're there. We can do it all.
Yeah, I think when you are able to see a patient, a lot of the times the patient does not really realize that they're having shortness of breath. But you could see it. You could see the nasal flaring. You could see the lip pursed, and they're not speaking in complete sentences. So as an asthma specialist, we see that all the time. So you really can't trust the patient, and they don't even know. But once you see them on the screen, you're able to at least say, are they ill appearing? Are they not ill appearing?
Yep.
And then you can look at different things. As an allergist, we can look at different things on the face, and we can make different diagnoses as well, just like every field. For the neurologist, there's a lot of neurological exam that they can do as well. So every field has their advantage to it. And virtual examination is showing that between observers, inter-observer agreement is very high. We're looking at it that way as well.
Wonderful.
Okay, we can close out. There's maybe one or two more questions. Let me just see. There's a lot more actually.
Just pick a couple more. I don't want to run the doctor over too late here.
So one question is about the elderly and their familiarity with technology. So given many patients we see are elderly and often technology illiterate, do you think there will be any significant barriers to making the technology mainstream in the near future?
Just like everything, there's a learning curve. So, but you'll be surprised how many patients at least have a smartphone. Like you didn't expect that to be so high in the South Bronx, but we're seeing 70% have it. And then someone in the home can always connect them. So it will always be an issue with technology for, not just the elderly, for everyone. Some people are just more capable than not. Some doctors, the same thing. So there is a learning curve. So the bottom line is you have to know your patients, and you have to have a relationship with your patient and your community. And that's the only way you can achieve your goals at this time, I think.
And Dr. Prasad, can you discuss the quality measures for primary care in COVID telemedicine patients?
We're not looking, I'm not looking specifically at that here with the primary care. I just do the asthma and allergy right now. But a lot of the, for example, the diabetics were able to do screening at home, look at their sugar levels. The hypertensive patients, if they have sphygmomanometers at home as well, we're getting their blood pressure. So there's a lot of quality measures that we could still use to look at those and to make a decision.
Okay. Here's one more question. So how are portable telemedicine kits, so with devices and video conferencing, how is that being used during this situation, the portable kits?
You can speak to that, then I will.
Yeah, unfortunately, in our area, we don't have a lot of the, in the homes, the portable kits because patients can't afford some of it. Some of the, like the diabetic strips and stuff like that, they do, the insurance covers it. So I think it depends on which area of the country you're at and obviously what the patients can afford and what they can afford as well. You also have to be careful. There's a lot of technology that's out there that it doesn't work as well. So a lot of companies claim that their pulse ox works or blood pressure kits. So it's good to have FDA approved technology. And there's a whole bunch of technology that's coming out that's making a lot of claims. So the provider have to use their judgment with that as well.
Yeah, and what we see is, so when you talk about the home and sort of portable kits, there's sort of two different types of mobile telehealth. One, as we talked about, is this, right, where you have an app, but objective data is in there. The other one is you can have nurses, and we do see people ordering this because this you know, the virus came on so quick. A lot of organizations are moving, and fortunately, there are certain larger cities that have been hit harder. So others, and that's why a lot of you are on the call. You're preparing for what could happen. Hopefully, won't happen, but might happen in yours. So we even see not just in the U.S., but we just got some even in Central and South America. South America, we just got a big order where their thing is, just portable kits. So that cart that I showed you, you can do the exact same thing. You can have it like in a suitcase, right? You can have a suitcase and you can have all those diagnostic technologies inside of that suitcase. You go to the patient's home, let's say patient has COVID-19, they're sick. They need to see the clinician, they're sick, but they're not to the point where they need to be in the hospital where you just want to manage them. The nurse could go in and be like, you know what? I don't need to see a doc. I'm managing the patient. They're okay. I feel comfortable. But if they needed to contact a doctor to look at different treatment options or make a decision on their clinical presentation, do they need to be hospitalized? You could open the suitcase up. You'd have live video on the other side. You would have all those medical devices. You could have spirometry, pulse oximetry. You could look at the patient, look in their throat, all of the different diagnostic things that we talked about earlier. So that's the way that they're using it. So either this, the patient on their own, or a nurse walking in with a suitcase from a mobility perspective. And for those patients that are more sick, but not quite sick enough where they think they need to be hospitalized, or they're high risk and they want to keep a closer eye on them.
Okay, great. I think that will be it for today. We've definitely gone well over time, but we appreciate everybody for staying on, those that you did. And Dr. Prasad, thank you very much for your time and for offering the insight and information into what you're doing. And thank you for being on the front line, taking care of the patients as well.
Okay, thanks, Dr. Prasad. Appreciate it. Thank you, everyone. Thank you, Carrie.